Hi, good evening, everyone. I'm excited to welcome you all for today's informative webinar on management of bronchial asthma. I'm Shabnam, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for today's evening, Dr. Ayush Pandey. Dr. Ayush is MBBS MD, FCCS USA, FIM, FPC, FNIV Spain, AASC. Dr. Ayush is a consultant physician, diabetologist, and pulmonologist based in Bhopal, currently working at CMCH and Mansarovar Diligent Care Hospitals. He leads the palliative care unit at CMCH and is trained in palliative medicine from the Institute of Palliative Medicine, India. A passionate digital health educator, he has created 500 plus medical videos and built a YouTube community over 1.5 lakh followers. Dr. Ayush is pursuing the executive program in healthcare management at IIM Shillong and collaborates globally as faculty with the University of Buckingham, UK, and as a medical consultant with healthcare firms in the US and India. Over to you, Dr. Ayush. And doctor, actually, you are on mute. Dr. Ayush, you are on mute.
Am I audible now? Is my screen visible, Shabnam?
Yes, doctor, you are audible as well as the screen is visible.
Okay. I hope my PPT is visible.
Yes, doctor, that's also visible.
Okay. So thank you so much, Shabnam, for the very warm welcome, and thank you, Team Mediversal, for conducting this webinar and inviting me again for this webinar. So I'm Dr. Ayush Pandey and already given the introduction. So let's begin the presentation. So to all the participants out there, I just want your a bit of cooperation so that I don't want this webinar to be a one-way conversation so that I just come, I read the PPT and the webinar ends. I want a two-way conversation with you all. So I hope you all are there with me on this, and I do hope that the questions and Q&As which I'll be discussing in the webinar in between, you will be asking and you will be answering to that Q&As so that the session becomes more interactive and you'll have a better learning of the topic. So let us begin the session. So management of bronchial asthma. So we'll be dealing what exactly is bronchial asthma, why exactly, it is important, and why the management of bronchial asthma is important. So as we all know that, asthma and rhinitis are frequently associated with atopy with preferential sensitization to airborne allergens. So what is, atopy? Atopy, you become allergic and you become sensitized to the most common allergens which are out there in the environment. So what can be these allergens? Anyone, having these symptoms of allergy, any kind of allergy? Having you or in your family have these symptoms of allergy, or you have dealt in your clinical practice this allergy? No one?
Yes.
So what
These
exactly?
allergens can also be dust related or pollen grains.
Yes, you are exactly right. I think it's Dr. Ashwarya. So you're exactly right. This can be dust. This can not only be dust, this can be pollens, this can be dust, this can be flowers, plants, fruits, you eat whatever in your home. So there are most common 70 to 80 allergens which you encounter almost on a day-to-day basis. Whether you go out, whether you stay in your OPD, whether you are there in your IPD. So these are the most common allergens and you are sensitized to these allergens. So atopic diseases can manifest themselves at different sites on the body, and they can cause skin reactions, can present with urticaria, allergic rhinitis, atopic dermatitis, conjunctivitis, even food allergy and asthma. So this can be, this can be the presentation. So allergy is not just, so what exactly is asthma? Anyone? What exactly is asthma? And why this asthma and rhinitis is linked up? Quick so that we can go ahead. So I just want, as I already told, I don't want a one-way conversation. Let's keep this a two-way conversation so that, You get to learn a lot of new things. I get to learn a lot of new things from you, and the session becomes more interactive.
Okay.
Bronchial asthma, allergy. Okay, going forward, so allergic rhinitis and asthma should be considered a single inflammatory process. Why? Because allergic rhinitis is a disease of the upper respiratory tract, and bronchial asthma is the disease of the lower respiratory tract. But why it is named as one disease? So if you look at the guidelines and the standard guidelines, they call it a one airway, one disease, because the inflammation or the starting point of asthma begins from the upper respiratory tract. It directly not starts from the lower respiratory tract. So it starts from your nose, right from the point where you start breathing your air. The air enters and it crosses all the larynx, pharynx, enters the trachea, goes to the bronchus. So from the upper respiratory tract, so the any disease which is localized to the upper respiratory tract, that causes allergic rhinitis, because it is a disease of the upper respiratory tract. So once it crosses below the level of trachea and it lands up into the lower airways, it causes asthma, which is the disease of the lower respiratory tract. So you see almost 70 to 80% of the patients of asthma, which you also see, I think, in your day-to-day clinical practice, they complain of either allergic rhinitis or any kind of allergies which is linked to asthma. And these are the nasal challenge or bronchial allergen challenge test, which is done, in which a chemical, mostly a methacholine or a histamine, is allowed the patient to inhale, and then the patient is allowed to perform a spirometry or a pulmonary function test to look at the abnormality or the changes in the airways. I hope you are clear with this, because if there is a allergy or if there is an inflammation in the allergic rhinitis in the upper airways or in the lower airways, that will be get reflected in your pulmonary function test, and especially the lower respiratory tract, the lower airways, they are sensitized, so you may get a obstructive pattern on the spirometry. So that's why a patient of asthma during his early phase may just have sneezing, persistent nasal discharge, and these are mostly associated with every change of seasons. So the patient, if controlled at that point of time, if immediately dealt at that point of time, the patient will not, progress to have asthma if the allergic rhinitis is controlled at that point of time. What are the most common lung diseases? Asthma, COPD, lung abscess, post-TB sequelae, lung cancer, and pneumonia. Any one of you can tell what is a sequelae? If you have heard, if you have seen in a day-to-day practice, what is a sequelae? Quick, so that we can go ahead. Okay. So this was what I was talking about. What was the impact of allergic rhinitis on asthma? Allergic rhinitis is, yes, a risk factor for asthma. So again, if I ask the question, what is a sequelae? Sequelae follows the disease. So any disease, especially tuberculosis, if this sets in your lung, it causes fibrosis. Most commonly, the lung parenchyma is destroyed. So that sequelae is fibrosis. And it follows the disease. That means if the disease has set in, the sequelae will definitely occur. So if the patient has a pulmonary tuberculosis, there are very high chances that the patient of pulmonary tuberculosis, once treated, will have fibrosis. So again, coming back to our topic, allergic rhinitis is a risk factor. And if patient have both allergic rhinitis and asthma, they will have more hospitalization, increase in the cost, and poorly controlled allergic rhinitis. If allergic rhinitis is not controlled properly, it will impair asthma control. So people with severe rhinitis are 4 times more likely to have poor asthma control. You just do not have to just control the asthma. You have to control allergic rhinitis also, because the gold terminology for this is one airway, one disease. Allergic rhinitis as a risk factor for asthma, yes. Important risk factor. Patient with allergic rhinitis have 3-fold greater chances, and they have more severe and persistent rhinitis. Patients who have more severe and persistent rhinitis are at a higher risk of developing asthma. Again, same allergic rhinitis. More than 40% of the patients with allergic rhinitis will have asthma, and more than 80% of the patient with asthma will have allergic rhinitis. This is a universal, this is very common, and it is fixed that allergic rhinitis has increased in the prevalence. Why this has increased? A lot of dust, a lot of pollution, changing environment, global warming, and because of all these things, allergic rhinitis is in the rise. And every one of you, mostly every second, third person, have that nose blockade, stuffiness, dribbling of mucus from the nose, early morning nasal congestion. So these are very common, and these are the signs and symptoms of allergic rhinitis. What do you think? Are we breathing fresh and pure air in the city in which we live? What do you think?
No,
No,
there's no
definitely no.
fresh air.
Yes, definitely no. We are not breathing fresh air. Why this is? Because you see this data, and it is very sad to see. If you see that most of in this top 10 are the Indian cities. Even we have defeated Pakistan in this. So the Pakistan is in the third number, and Gurgaon and Ghaziabad have the rank 1 and rank 2, and there is Noida, Patna, Lucknow. So very sad to see why there is this in the rise. This trend is on the rise. So we talk about air quality index. You see everywhere in the media. What is this AQI in which what we talk about? So this is the quality indicator of air. So anything less than 50 or between 50 is a green zone. That means you are breathing fresh and pure air. That air is at least which has to be breath. So anything which goes beyond that, it falls in the yellow, orange, red, purple, and maroon zone. And you see that, most of these cities which are adjacent to Delhi or Delhi NCR, every year, especially in that, November, December season, you see that Delhi has that buildup of smoke and people have that buying mask and everything, all kind of purifiers. And so why this happens? Because that air quality index get poor. And why this happens? A lot of construction, a lot of pollution, global warming, and so. So coming back to our topic, asthma. So it is a disease with many variations characterized by chronic airway inflammation. The term chronic is important. It is not an acute condition. So basically it has two key defining features: history of respiratory symptoms such as wheezing. What is a wheeze? That, whistling sound. That whistling sound, and that is the audible whistling sound. So if you are near to the patient will come, or the patient relative will say that Dr. Saab, iski CT baj rahi hai, or every time he breathes in air or he breathes out air, there is that whistling sound coming, and that is a wheeze. So audible wheeze, when you auscultate that wheeze through that stethoscope, that is known as rhonchi. So anything which is audible on the stethoscope is rhonchi. Audible, which you hear through the bare ears, is wheezing. So characterized by wheezing, shortness of breath, chest tightness, and cough that may vary with time and intensity. Characterized by expiratory airflow limitation. So is asthma an allergic disease? Yes or no? Quick.
Yes.
Yes, exactly. Asthma is definitely an allergic disease. Risk factors: uncontrolled asthma symptoms, medications, patient who take these medications, beta blocker, NSAID, aspirin, high SABA, poor inhaler technique. This is very important, poor inhaler technique. Why? Because you don't check how the patient takes inhaler, how much drug is going inside, what is the technique, and that's why the patient comes and he say that, doctor, you have given everything right, you have diagnosed my condition, you have given the medication also, but it is not working. I am having that same shortness of breath, chest tightness, and everything. Why? Because you have not checked the technique of the inhaler, whether the patient is pressing inhaler first and then breathing. There is no hand-mouth coordination. So this is very important. Comorbidities: obesity, gastroesophageal reflux, chronic rhinosinusitis, because again, one airway, one disease, smoking, air pollution, allergen exposure, and low FEV1. What is FEV1? Forced expiratory volume in 1 second. And this we calculate on spirometry. So we tell the patient to inhale amount of air, and then we tell the patient to blow out quickly. And so that the expiratory air which he has blown out in 1 second, that is FEV1, and the expiratory air which he blows out through the force, that is known as forced vital capacity. And these two ratios, FEV1 by FVC, will get you to diagnose asthma. Elevated FeNO, fractional exhaled nitric oxide. So any patient who has a diagnosis of asthma or being diagnosed asthma, this nitric oxide levels, if you measure, and this is measured through FeNO machine, this is not measured on spirometry. This has to be very clear. This is on the higher side. So the normal levels are 0 to 25 normal, 25 to 50 in the mid range, and greater than 50 is a sure shot diagnosis. Sputum or blood eosinophil count on the higher rise. Some signs and symptoms: cough, shortness of breath, sneezing, nasal congestion, blood in sputum. So what is blood in sputum? The medical term for this is, anyone quickly? Blood in sputum is known as?
Hemoptysis.
Yes, exactly. Very well answered. The blood in sputum is known as hemoptysis. So bleeding from the respiratory tract below the level of larynx is hemoptysis, and hematemesis is blood through the,
Vomiting.
yes, vomiting. Exactly. So I have a very lovely audience participating. Chest pain and palpitation. Going ahead. So this can be the signs and symptoms of most of the lung diseases, and this can, mimic fever and fatigue. Again, coughing, chest tightness, and this is the, hemoptysis. So what measures are we taking to breathe fresh air? What exactly you think? What are we doing as a citizen, as an Indian citizen? Are we doing anything or nothing? What do you
Deep
think?
breathing exercises.
Is just buying air purifiers enough? Now there is air
Yeah,
purifiers for cars also, and that great innovation has been come up.
Yeah.
So air purifiers are, now these marketing companies are so clever, especially in Delhi NCR region. So where the pollution gets worse, there you see a lot of ads of this air purifier. So can you carry this air purifier everywhere? And they don't do that much function. So this is again, everything has an effect along with the side effect. Now people are so conscious, they are carrying this in the cars and so. So what are the most common cause of lung diseases? The famous, we ourselves.
air pollution.
No, we. Why we? We are contributing to air pollution. We are contributing to, some of them are indulged in, not everyone, but again, some of them are smoking. Some of them are causing air pollution. We are using vehicles, which are again producing, either burning of diesel and exhaust fumes. Causes of the lung diseases can be genetic, especially asthma. So if your grandfather or mother or father have this asthma, there are high chances you may have, or your siblings, or you can have this. Hello. Yes. So genetics, allergies, smoking, air pollution, bacterial and viral infections. Yes, occupational, Dr. Nazia, very well said. The patient who is working in especially, all these factories. So occupational asthma is again on the trend of rise, where there are production of fumes, you come in contact with all these things. So what is the definition of bronchial asthma? So why am this, a bit of, highlighting on this brief of asthma? You have to understand this topic, then you will be able to understand how to manage this. Yes, drug NSAID, as we already discussed, the drugs can be the causative factor. Mogorgini, yes. So asthma is a heterogeneous disease characterized by chronic airway inflammation, history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, cough that may vary in intensity with variable expiratory airflow limitations. One or more symptoms may predominate, but airflow limitation may later become persistent. So what is childhood asthma? Again, the same airway obstruction, airway inflammation, and airway hyperresponsiveness. This airways, the lower respiratory airways, there is inflammation, continuous inflammation going on. And we'll be discussing in the further slides what exactly is this inflammation. Because of that inflammation, the airways become hyperresponsive and the airway becomes narrow. What is the prevalence? Up to 25%. And you see this data, around 2 lakh people die from asthma. This is very sad to see. And 5,000 deaths are there in the United States. In India, again, sad to see the respiratory diseases are on the rise. So after cardiac diseases and stroke, the third number is respiratory diseases. So this is the normal anatomy of the respiratory tract. Larynx, trachea, and the trachea further divides into main bronchus, primary, secondary, tertiary, and then terminating into alveolar duct, alveolar sac, alveoli. So this is exactly what happens. So any kind of allergens which you come in contact, either it is a air pollution, virus, chemical sensitizers, it causes inflammation. Because of that, there is airway hyperresponsiveness, airway limitations, and all those symptoms. What is the asthma attack? So exactly you see where is this mechanism which is occurring. So you see in the smaller image there is a normal airway, and because of that persistent inflammation, because of that persistent causing of infection or inflammation, especially there is mucus production also, and that is causing narrowing of the airways. Because of that narrowing, there is smooth muscles which are lined up in this airway. There is hypertrophy of the smooth muscles, and that causes narrowing of the airways. So there is constriction, there is narrowing, which causes bronchospasm because of that airway inflammation, and which further causing airway limitation. So this is exactly the normal airway which we see in the first, then coming to the asthma, and you see in attack. What is the asthma attack? There is exacerbation, and you see that how much narrowing is there. The smooth muscles are so constricted. Air doesn't come out of the alveoli, and there is all that expiratory airflow obstruction. Again, same in this image, narrow airway, tightened muscles, inflamed, thickened airway walls. So this is exactly the basic mechanisms. You come in contact with allergen, it activates macrophage dendritic cells, mast cells again, which further activates the eosinophil neutrophils, which again cause nerve activation. There is epithelial shedding, mucus hyperplasia, there is formation of mucus plug, and because of that, there is plasma leak edema, which the nerve activation causes bronchoconstriction, hypertrophy, or hyperplasia. Allergic bronchitis, yes, but allergic bronchitis is not exactly as same as bronchial asthma. So acute inflammation further leading to chronic and structural changes. What are the structural changes which have occurred? Smooth muscle hypertrophy, airway narrowing, thickening, mucus plug. So these are the common triggering factors. As someone in the earlier discussion mentioned about these are the most common: animal danders, dust mite, pollen. Others can be smoking, viral aerosols, drug, change in temperature, or viral infections. So how the diagnosis of asthma is made? Now coming to back to our topic. As the patient can present to you with persistent cough, wheezing, dyspnea, but this is seen in approximately 30% of the patient. What exactly can be the atypical features? Just cough variant asthma. And this can be mostly cough variant asthma patient will just have coughing, will have just dry coughing, maybe sometimes associated with expectoration, but it will get, worse with every coming in contact with allergen. So it can mostly be a nighttime coughing, nocturnal asthma, activity, you do exercise or so, persistent cough, recurrent pneumonia. So diagnosis of asthma is mainly how this is made. Anyone? How this is made? Asthma? Quick diagnosis of asthma.
Clinical diagnosis based on the combination
Yes,
of history and
exactly. Clinical, 100%. Clinical, no ABG. Asthma, ABG, that is the diagnosis is done through the asthma exacerbation, just to see how much is the, in which respiratory failure. In asthma, mostly there is type 1 respiratory failure. So ABG, mostly we do in an exacerbative phase. How much oxygen to give, whether the patient has retained CO2 or not, maybe. So diagnosis of asthma is mainly made clinical. So you do this, PFT spirometry, and what exactly is the spirometry criteria? Eosinophil levels, no, eosinophil levels can be there, but the short diagnosis of asthma, the patient will present to you with classical history. Maybe shortness of breath, vary in intensity, time, triggering factors, change in weather, nighttime more symptoms or not. So right from your history only, you can clinch that the patient can have asthma or not. So the first gold standard is yes, spirometry. PEFR, as Dial is saying, PEFR can be there, but it is not that much reliable indicator as PFT. Alpha-1 antitrypsin is basically done for genetic cases, but especially done for, genetic COPD mostly. Alpha-1 antitrypsin is a protein which is being produced by the liver. So peak flow variability greater than 20%, reversibility. So if you go to the spirometry criteria, it is the GINA guidelines clearly states that Improvement in the bronchodilation in the spirometry of FEE1. Many of you get confused that it is FVC or maybe a ratio. A improvement of FEE1 greater than equal to 12% and 200 ml is a short diagnosis, and that's how you differentiate asthma from a COPD. So these can be the 4 guidelines, and these has taken from the ERS, European Respiratory Society. Improvement in FEE1 greater than equal to 12%, 200 ml after a 2-week course of oral corticosteroids or a 4 to 6 week of inhalational corticosteroids. Diagnosis clinical. Again, we have discussed airflow obstruction is reversible. What is that reversibility? That reversibility is seen in the FEE1. So you do a spirometry before giving a bronchodilator, short-acting bronchodilator. After giving a SABA, you again do a spirometry. And if there is improvement in this FEE1 levels, that is known as reversibility, and that is how asthma is being diagnosed. Again, blood counts may not help. Peripheral smear may show eosinophilia because of that allergy. Chest X-ray done to rule out secondary infection. PFT, gold standard spirometry. PEFR can be done, but if you compare spirometry in PEFR, spirometry is more reliable than PEFR. But if you don't have access, again, PEFR can be done. Differential diagnosis of wheezing that I already told. It can be early infancy to birth, infancy to childhood, or late childhood. Aspiration syndromes, bronchiolitis, foreign body inhalation during early infection. During early infancy, bronchiolitis, transient wheezing, foreign body inhalation again during from early infancy to childhood, and late childhood, asthma, congenital heart disease can be differential diagnosis for wheezing. Now coming to the classification, grade, symptoms, nighttime, and PEFR values. This is important because this is how your whole management will work. Okay, this is how your whole management will work. Grade 1, grade 2, grade 3, and grade 4. So if there is less than 3 symptoms per week, as I already discussed in that, and especially that nighttime symptoms and PEFR greater than 80%, less than 20% variation, that is grade 1, and how this again grade 2, 3, and 4 works. So if you see greater than equal to 3 per week, if your daily symptoms are limited, you are affected, and if there is continuous limited physical activity and nighttime symptoms are frequent, you fall in that severe persistent grade 4 category. Acute severe attack. What is acute asthma attack? 2 breathless, respiratory rate, there is severe tachypnea, heart rate is there is severe tachycardia, PFR less than 50%, poor or only transient response to bronchodilator, or worsening despite 2 to 3 doses of recent dose of bronchodilator at 15 minutes interval. What are the symptoms of life-threatening asthma? The patient is unable to talk. He is not able to talk only. I think someone is having difficulty in hearing. If the team can look into it, he is persistently messaging. Cyanosis, the patient is blue, cyanose. There is feeble chest movement. There can be a silent chest. What is a silent chest? So if you put the stethoscope on the chest of the patient, you won't see any sound. There is absent breath sound. The patient is exhausted, tired, altered sensorium. There can be a CO2 retention also in the asthma. Oxygen saturation less than 90%. So acute severe asthma, consider differential diagnosis, oxygen. So you have to maintain saturation to around 90 to 95. So coming this to oxygen, what do you think? Oxygen, how much oxygen we have to give? So if a patient comes to you with 80% or 85% saturation at room air, and there is a 15 liter, especially, in that hospital setup, the maximum you can give of oxygen is of 15 liter per minute. So how much oxygen will you put the patient on? The patient has come to you with 85% oxygen.
We'll target to 92%, 92 to 94%.
Why not will target 98 to 100%? What exactly you think? The only reason we don't target it, because oxygen acts as a drug. If you give more oxygen, there will be cut off of the ventilatory drive. The brain will get a signal that oxygen is coming from the outer source. So the brain will not signal to you to take or inhale oxygen. And because of that cut off of ventilatory drive, you will be or the patient will start retaining carbon dioxide. And that will be the rise in CO2, and that is more fatal. So it is a very common physiological phenomena which we observe in the hospital settings. A patient come to you gasping and tachypneic, you put the patient straight away on 10 to 15 liter oxygen. No, the patient will not die with less oxygen support, but he will definitely die with more oxygen. because he will retain CO2, he will become altered, he will collapse, and till the time you will put him on ventilator, the patient will crash very badly. Coming back again, initial treatment of acute severe asthma, nebulized salbutamol, 3 doses, 20-minute interval, 0.5 ml with 3 ml normal saline, again greater than 20 kg, 1 ml. Nebulized ipratropium, less than 1 year, 0.5, greater than 1 year, 1 ml. And steroids, again, methylpred, 2 mg per kg stat, followed by 1 mg per kg 6 hourly, or short-acting hydrocortisone, 10 mg per kg stat, followed by 5 mg per kg 6 hourly daily. So this is the chart. Not improved, you reassess, and again magnesium sulfate in normal saline can be given and can be repeated again. Used or maybe not used also, again magnesium sulfate used in exacerbation has always been controversial. So some clinicians prefer, some don't. Again, some guidelines prefer to use it. Again, terbutaline infusion, and then if not improved on that, aminophylline infusion. But then you have to reduce terbutaline infusion by 50%. And again, if again not improved on this, all this, then intubate the patient. There is no much, you have options because the patient will crash. The patient of a exacerbation, the patient of acute severe asthma will not give you so much time to or try or to do a bullet therapy or so. What are the indications for intubation? When you will ventilate the patient: cardiac arrest, comatose, severe respiratory distress, silent chest. If you are not able to auscultate anything, the patient is fatigued, there is use of respiratory muscles, the patient is gasping, okay, you have to intubate it. You have to intubate it. We don't do this for child. Someone is asking, because the child management of asthma is completely different. But in this session, we are just sticking ourselves to management of adult asthma, because child management, the doses and drug doses is completely different. Talking about the relative contribution, indications for intubation, you see on ABG, PO2 less than 60%, PCO2 greater than 65, and metabolic acidosis. Intubate, straight away intubate. If you wait and watch, the patient will crash. Mild asthma, what is mild asthma? That is well controlled on low dose ICS or as needed only ICS formoterol. What is a low dose ICS? Anyone? What can be a low dose? What is severe asthma now? That remains uncontrolled. You can answer between, I'll just stop. Anyone low dose ICS? So severe asthma, uncontrolled despite high dose ICS. What is a high dose? That require high dose ICS LABA to prevent it from becoming uncontrolled. So you have a terminology known as high or low dose. You straight away don't give an inhaler having a Foracort or any kind of Seroflow having that 400, 800 preparation of either a budesonide or a fluticasone. You have to understand what is a low and high dose. So what exactly is the management of asthma involves? It involves assess. You have to assess the patient. You have to adjust dose accordingly. You have to treat, and then you have to review the response. So this assess, how this assessment is done. Symptoms, check for the comorbidities, check if the patient is already on inhalers, check the technique, and then the patient preferences. The patient preferences has to be very kept in mind. Whether the patient is comfortable on nebulization therapy, whether the patient is comfortable on DPI, whether the patient is comfortable on MDI. Then you adjust accordingly. And then you review it. You have to review all the side effects, exacerbations, patient satisfaction, lung function. So if Dr. Bilal, I'll just come to it. If you're in remote areas, you have to understand this. If the patient is having audible wheeze, or if the patient has come with exacerbation, you have to give inhalational therapy along with a steroidal therapy. So you can definitely give a hydrocortisone or a methylpred. So you can definitely give, or a long-acting, maybe dexamethasone can be given, but nebulization therapy has to be given. Coming now to the drugs. Now, what are the relievers and what are the controllers? So relievers to treat bronchospasm and relieve acute attacks, and controllers to prevention of further attacks. So these are the two categories of drugs, relievers and controllers. So in relievers, you have short-acting beta-2 agonists. There is salbutamol, terbutaline. Non-selective, you have adrenaline. Inhaled steroids, you have beclomethasone, budesonide, fluticasone, and these are the controller therapy. These are not the reliever therapy. So reliever therapy is basically given in acute attack. Mast cell stabilizer controller, sodium chromoglycate and nidocromil. Again, relievers, anticholinergics, ipratropium, oral steroids, and theophylline. Coming to the controllers, LABA. LABA, what is long-acting? Salmeterol, formoterol. Again, some more, bambuterol. Methylxanthines, theophylline, and oral prednisolone, leukotriene antagonist, montelukast, very common, Monter LC, Monter FX by the name of brands which are there in the market. Coming to the grade 1 management of intermittent asthma, controller and reliever, again none required because it is a intermittent asthma. So you relieve the symptoms. You just relieve the symptoms. And how do you do this? And how do you, make sure that it is an intermittent asthma? We have discussed this in the previous slide. What exactly is the intermittent asthma and what exactly is the what exactly is the further steps? Inhaled beta-2 agonist, not more than 3 times a week, or inhaled beta-2 agonist or chromone prior to exercise or allergen exposure. Coming to grade 2, mild persistent, you put on daily low dose inhaled corticosteroids, less than 400 dosage, or inhaled sodium chromoglycate, that is nidocromil or leukotriene or theophylline. But the reliever, how you relieve? Again, beta-2 agonist can be used as a quick reliever. Coming to moderate persistent, preventer and reliever, low dose inhaled steroid plus inhaled long-acting beta-2 agonist plus or daily medium dose. So in the previous group, there was low dose, if you come to this, but in this, there is medium dose of steroids, that is 400 to 800, and reliever is the same. Reliever is beta-2 agonist. So this was what I was talking about. What is a low, what is a medium, and what is a high ICS dose. So low is 100 to 200, greater than 200 to 400, greater than 400, low, medium, high. And this is based on the type of steroidal preparations in the inhaler. Whether it is a beclomethasone, whether it is a budesonide, whether it is a cisalosonide or a mometasone. So it varies from adults, that is 12 years or greater, or children 6 to 11 years. Now coming to the group 4, high dose. In the previous, we have seen medium dose. High dose is greater than 800. Again, you put on long-acting bronchodilator, theophylline, and these are controllers. Reliever, because there is a reliever, is mostly used for acute attacks, and that is mostly dealt with beta-2 agonist. So these are the step 1, step 2, step 3, step 4 combined. And this is again, you have to switch from step 1 to step 2, step 3 to step 4. But if the patient symptoms get improved, you have to also taper it down accordingly. So these are the GINA standard guidelines. What exactly you will do in the step 1 and 2, step 3, step 4, and step 5. How you will increase the dose and what else medication you will put on every steps. This is very important because every asthma patient should not be managed just by giving inhalers, just by giving nebulizations at the same dose. Because if you will do this, if you don't understand which step the patient fall into, then the patient asthma will be worsened. And because of that worsening, the next time patient will come to you, he will not get relieved with the previous medications which you have given to him. So step 1, 2, low dose ICS formoterol. Again, step 3, ICS formoterol. Step 4, medium dose, because you started from low, medium, and then again a high dose may be needed. And again, some biological therapy is being now the trend in the market. And this is the GINA guidelines for management of 6 to 11 years children. Again, an important slide. So you have to understand this stepwise treatment option. So why exactly track true with SAVA as the reliever? So someone in the chat also asked that why, salbutamol therapy we cannot give. So can use track 2 if track 1 is not possible. So can also consider track 2 if a patient has good adherence with their control and has no exacerbations in the last 2 months. But what exactly you think? Can a patient of asthma, can we only give SAVA to the patient if the patient is well controlled? What do you think? What exactly is the gold standard? Why not twinkle if the patient is stable? Why exactly he just can't be given a SAVA? Because the gold standard for management of asthma is inhalational corticosteroids. You have to give that inhalational corticosteroids. Putting the patient just on SABA will not work. What is long-acting muscarinic antagonist?
Deuterium bromide.
Yes, exactly. Should not be used as monotherapy again because of increased risk of exacerbations. Patient with exacerbation should receive at least medium dose ICS LABA before considering add-on LABA. Again, why oral bronchodilators are not recommended? So we have seen that aspirin tablets, which are used by the all quacks in the market. So why these oral theophylline salbutamol tablets are not recommended? Why? Slow onset of action, less effective for symptomatic relief, more adverse effect, and they do not treat the airway inflammation that is characteristic of asthma. So all that thing, oral bronchodilators is not being used. Home nebulization of SABA, as I already told, it will increase the risk of severe exacerbations. It will increase the risk of asthma mortality. It will increase risk of transmission of infection. But again, now these are the new trends which are there in the market. Use of biologicals, anti-IgE, anti-IL-5, anti-IL-4R, and anti-TSLP. This is again a costly therapy, and again the use of biologicals is definitely, I must say that the use is there and it definitely benefits, but they have a long-term role. If you expect the miracle to happen within maybe a month or maybe some weeks, because the treatment of these biologicals either given as a subcutaneous therapy or a sublingual therapy, you either also give a immunotherapy for the patient or you give a subcutaneous preparation. You need to have wait and watch, and this will be a costly preparation. So most of the patients, because a injection of omalizumab can range from 15,000 to 25,000. So why anti-Ig and all these therapies are being now come up in the market? So this will help the patients to prevent that further worsening of symptoms. But again, the role is, I must say, so-so role. But again, good role is there of biologicals. But again, long-term role with expensive, associated diseases, as I already told, allergic rhinitis. So you have to treat allergic rhinitis also. And that treatment has to be done with intranasal budesonide or fluticasone or oral antihistaminics. GERD, if there, the GERD treatment has to be done. So how often should the patient of asthma be reviewed? 1 to 3 months should be there after starting the treatment, followed by 3 to 12 months. So in pregnancy, review every 4 to 6 weeks. So a pregnant female has very high chances of, going into exacerbation. But after exacerbation, if the patient has an exacerbation, review visit after 1 week should be scheduled. What is exacerbation? Anyone?
Worsening of disease.
Exactly. One word, worsening of the signs and symptoms. Stepping up asthma treatment. So when you step up, as we already discussed, how you will go from step 1 to step 2 to step 3. If symptoms or exacerbations persist despite 2 to 3 months of the controller treatment, assess for common issues such as incorrect inhaler technique, very important, poor adherence, modifiable risk factors. You have to look into this. Short-term step of treatment for 1 to 2 weeks should be done by the clinician or by a patient, and you have to give a written asthma action plan. So nowadays, the smart clinicians and the smart pulmonologists have started giving a patient with a sheet which contains the asthma action plan. So what it contains? It is a sheet which contains all the signs, symptoms, whether you have shortness of breath while on walking, while doing household work, while going out. So it has all that checkbox, just kind of MCQ. So if the patient has that worsening signs and symptoms, the patient himself fills that box or check that box. So that once he or she visits the clinician, so the clinician will have that asthma action plan with himself, whether to step up or to step down that therapy. Stepping down. When a good asthma control is achieved and maintained for 3 months, choose appropriate time. Assess for risk factors, very important. A written asthma plan, very much. And a follow-up visit has to be scheduled. This is very important. What do you think? Is asthma and COPD are the same diseases? Why no? So if the answer is no, why no?
Asthma is reversible and COPD is irreversible.
So there is a point also, someone discussed in the chat, asthma COPD overlap. So if you see a asthma COPD overlap condition, you won't get a spirometry reversible in some cases. So just correlating with spirometry, this can be a clinching factor especially if there is a asthma COPD overlap condition. So exactly these are not the same diseases. These are different diseases, but these both are obstructive airway disease. They're definitely a different clinical entity. COPD is obstructive. Asthma is also obstructive. Someone in the group answered both are obstructive airway diseases. Is asthma completely curable? Quick. Can be 100% cure asthma?
No,
Why no?
because
If
it
no,
is
why
an
no?
allergic disease.
Yes, you are right. It is 100% allergy cannot be cured. It can only be prevented. What is the treatment of asthma? So inhaler pumps nebulizers which contain inhalational corticosteroids are the first line at the mainstay of treatments. Antibiotics, oxygen, cough expectorants, and mucolytics. If there is secondary infection, if there is an exacerbation, then you might require antibiotic therapy or oxygen. Chest physiotherapy play a very important role, especially palliative care, even at home. Coming and the counseling of the patient and especially for the relatives is very much important because you have to make sure and you have to tell the patient that this disease can never be 100% cured, but it can be prevented. So you have to put them that in mind and you have to counsel that why you have to take inhaler. You have to make them. So these can be, again, expectorant, mucolytic, antibiotics, oxygen therapy. The gold combo, which are there and which are being prescribed by everyone. So the patient will come to you that you see with the inhaler, he will come to the OPD straight away. A Foracort inhaler of 200, Foracort inhaler of 400, a Seroflow, and these are not being controlled. So what you'll do? So these are the most golden combo packs. So most of the quacks doesn't know what is the content of this also. What is the content of Foracort? What is the content of? These are just the brand names which are there. So these are the most common, So every patient you cannot just treat, take a one puff, take a two puff. So you have to make sure, which we discussed in the previous slides, that what exactly in which categories the patient follow. Now, again, golden duo, which is being you come in the hospital. So if the patient comes to you and the patient comes up in the hospital with the exacerbation, nebulize करवा दो dual Budecort से. कुछ नहीं तो nebulize करवा दो. If there is a shortness of breath, if there is anything, just the patient is having some chest tightness or so, give a nebulization with dual Budecort. Anything. So golden duo. So what do you think? Is inhalers, pumps, nebulization safe in asthma or not? Are they safe? Quick?
Yes.
Yes, exactly. They are safe. Does they cause addiction? Are they addictive?
No.
Yes.
Someone said yes. So the answer to this is no. They're not at all addictive. What patient's parents say to a doctor? So you tell the patient you have to take inhaler, what they'll say to you? So what are the most common? The patient they come to you, if you tell them to take inhaler for 1 month, 2 months, 4 months, maybe for 6 months, they cause dry mouth, okay. It can be a side effect. What else the patient say to you? Why they don't
Tremor.
want to take inhaler?
Dependent, inhaler dependency.
Yes, आदत पड़ जाएगी. It will cause harm. So they will use it on a SOS basis. So this is the most common myths or the misconception which the patient have. So why this pump nebulization inhalers should not be taken on a SOS basis? Why? So what do you think? So if you have an attack, one day there is a rainy season and your asthma gets triggered and you started suddenly having shortness of breath and you take a pump of asthma, you get relief. After again 5 days, you have the same symptoms, you take a pump of asthma, you get relief. So whether it should be taken on a SOS basis or not?
No.
Why? If no, then why? Definitely you have to tell the answer also. They cause more harm than good. Airway shrink over a period of time if not given on a daily basis. As I already discussed in the previous slides, that there is bronchoconstriction, there is airway narrowing, there is smooth muscle hypertrophy. So if you don't give inhalational corticosteroids, there is a term known as airway remodeling. खुद से airway tries to remodel itself. So once that remodeling sets in, the airways, if this is the airways, it will get compressed over a period of time. So that SOS therapy will cause more harm than good. Are inhalational steroids safe in asthma?
Sir, is there any risk of adrenal insufficiency kind of things or that excess, sir? Anything?
Not at all. Inhalational corticosteroids are completely safe. Inhalational corticosteroids are the most safest preparation. You have it. Oral corticosteroids, I do understand it has a lot of side effects, but inhalational corticosteroids are safe.
And sir, how it pounds on a obese patient or some patient with some comorbidities, sir, like hypertension, diabetes?
So exactly, inhalational corticosteroids doesn't increase your sugar levels, doesn't increase your HbA1c. If someone asks in the chat also, it has no role in increasing your glycemic control. It doesn't, it worsens it. It doesn't worsen also your hypertension also. If your hypertension or diabetes is well controlled on your anti-glycemics or anti-hypertensive therapy, you can well take inhalational corticosteroids. Do not worry. Are inhalational steroids safe in asthma? As we already discussed, yes, they are safe. Are they safe for asthma in pregnancy?
Yes.
Yes.
Yes, they are completely safe. For the must-on travel gears, you will tell the patient, if a patient, Saba, Laba, why Saba? Quick. You will tell the patient to have a Saba.
In acute exacerbation, we need to
Yes.
use SAPA.
Reliever, the term reliever, the controller, Laba. And if the patient is of old age, you can, if the patient is not able to take that MDI DPI preparation, a nebulizer. Now you see this portable nebulizer has come up in the market. And this is again, which are the new trend which has come up. This 3-ball incentive spirometry, a very good exercise. Again, if you cannot take a incentive spirometer, to make sure to improve your lung function capacity, you can either blow in the balloon or you blow out. This will again help you to increase your lung capacity. Good things we can do. We can at least plant a tree to get that get pure air, or to prevent that air pollution, we can do carpooling. So again, I hereby end my session. I
Thank
hope
you.
I was able to complete on
Excuse
time.
me,
And
doctor.
yes.
Excuse me. Yeah, so taking the SOS inhaler, yeah, it's not supposed to be taken SOS. It'll
Yes.
because the airways become hypertrophied, you're saying over the time. Then why the
Yes.
attacks are coming only very rarely? Then in that case, attack should happen every now and then if that
See,
hypertrophy
there
is
is
taking place.
continuously airway remodeling which is going on, and the patient may not have that signs and symptoms, some patient, but if a signs and symptoms appear, that can be so worse that maybe not be able to be controlled with all that inhalers, maybe all that nebulizers, and ultimately you have to put the patient on ventilator. So the patient ultimately, वो patient आपके पास तब आएगा जब उसके signs and symptoms इतने worse हो जाएंगे, और till the time the patient can be asymptomatic. So if you see a patient of cardiac, maybe a patient of any lung disease, he come to the usko heart attack hua, and maybe there is a 80%, 90% blockage. So the patient may be asymptomatic at that point of time. So the patient may not have any signs and symptoms, but the airway remodeling is going on at the back end. So the patient will ultimately come to or present in the hospital at that time in which these nebulizers or these inhalers, MDI, DPI, will not work at that, maybe not work at low dose, maybe not work at medium dose, not even the highest of doses. So what you have to do ultimately, you have to intubate the patient, you have to put the patient on ventilator. And there is very, high risk of patient, being collapsed or maybe of mortality of the patient to happen.
Okay.
Thank you so much, Dr. Ayush. I request everyone to write their questions in the chat box. We will
What is
start.
this tick which has come up? I haven't used this.
Which one?
I don't. Okay.
Everyone, please write their questions in the chat box. We'll start the Q&A session. Dr. Ayush will answer one by one.
I hope I'm very clear that you have to have that understanding of that every asthma is not like for a cot de do nebulize kar do, you give a hydrocot shot, but you have to have that clear understanding which step and how to manage the patient accordingly.
Dr. Jobin is asking, can injection darifilin given in acute attacks?
See, darifilin injection, being a critical care, intensive care, and being a physician myself, MD medicine, I don't prefer darifilin, and the use of darifilin has now also been, outdated and obsolete. If you see the standard guidelines, the darifilin is causing more harm than good. So nowadays, if you see the darifilin, because of that cardiac safety, the cardiac safety of darifilin is very controversial. So you have that, most of the patients may land up into either a arrhythmia or so. So the cardiac safety, the cardiac biosafety of darifilin is not very good. And again, if you have to give especially a filins or so, you can either give a aminofilin or so. But again, darifilins is very much controversial also. Again, aminofilins is also not much indicated nowadays. There is acibrophyllin which has been come up into the market, so darifilin is definitely not at all to be very much prescribed, and it has been obsolete also from the standard guidelines, which if you look about the GINA guidelines or the ERS standard guidelines.
Dr. Amrita is asking, just a second. Is it required to do nebulization in asthma attack?
Yes, of course. This is the gold standard of treatment. If there is the asthma attack, what you will give? The whole and sole prime treatment is nebulization. You have to give nebulization. First with a reliever, and then if the patient is reliever, every 15 minutes you can give a SABA at least for 1-2 hours. And if the patient is settled, then you switch the patient to LABA, long-acting bronchodilator, which I already discussed.
Okay, Dr. Deepesh is asking doxycycline oral tablets for cardiac safety.
Doxycycline, again, it is comparatively safe, but again, you can give oral doxycycline. Now, doxycycline has been come up either as a plain doxycycline or it has come with that, Montelukast kind of combo preparations. If you go in the market, you will see a doxycycline Montelukast dual combo which is there. So again, it can be used with a bronchodilator, but the whole and soul, if you look at the treatment of asthma, the gold guidelines and the standard guidelines is a nebulizer or an inhalational corticosteroids with long-acting bronchodilator, that is a formoterol, and inhalational corticosteroids, that is budesonide or fluticasone. And again, if you have to give symptomatic treatment, you can give doxycycline. But again, anti-allergics, all that nasal steroidal spray, if there is an anti-allergic rhinitis, if there is persistent nasal congestion, so you have to treat that also.
Dr. Zia is asking, if a patient has tachycardia, then which drug is used for nebulization?
So see, if the patient is tachycardia, you can give, don't give them salbutamol. You can give a levosalbutamol, which is by the name of Levolin, if you see there in the, especially in your setups. So two things which are there, Duolin, Levolin. So levosalbutamol and plain salbutamol. So better levosalbutamol has comparatively better role in dealing with, tachycardia patients, especially. So it is by the name of Levolin, which is there in the market or in your hospital settings, which you see. So it doesn't causes that tachycardia as compared to Duolin.
Okay, so one doctor is asking, if a patient present with rhinosinusitis, can we predict that the person may have asthma in future?
Yes, yes. As I already told, 40% of the allergic rhinitis patient will have asymptomatic asthma, and 80% of the asthma patients will have allergic rhinitis. So you treat allergic rhinitis then and there itself, because there are very future chances of developing asthma if that allergic rhinitis is not controlled.
Dr. Twinkle is asking, is a long-term corticosteroid inhale can develop common fungal lungs infection?
No, fungal lung nahi, but if the patient is immunocompromised, but make sure this, you always tell the patient to wash or to rinse his this mouth after water, after taking a nebulization therapy, after taking an inhaler therapy or a dry powder inhalational therapy. Why? Because that powder or that spray or that inhaler which the patient has taken, some part can get stick to your inside of the cheek or to the backside of the throat. That can cause, oral fungal infection that, if not controlled, can, trigger. That can further land up into that, lower airway tract fungal infections.
So Dr. Kamlesh is asking that, is it mandatory to give 3 nebulization at 20 minutes apart if the symptoms relief after first nebulization?
It is better actually because the guidelines say that if the patient is of an acute exacerbation which has presented to you, you at least give it because एक nebulization के बाद the patient can get some relief. But if you stick to the guidelines just for the controller therapy and for the better care, because the patient has landed up into the hospital, so it is better to treat accordingly, just to follow the guidelines than to stop between because half treatment can cause more worsening than doing good.
Okay, so one doctor is asking, can we give levosalbutamol with budesonide nebulizer?
You can give, definitely you can give. Yes, levosalbutamol is a short acting, but budesonide plain neb. So why do you want to give a plain budesonide nebulization with a levosalbutamol? So this is again a SABA you're combining with ICS. So if you're suspecting an attack, this is fine enough. You can give, but if you are suspecting, if you want to put the patient on long-term therapy, you switch this levosalbutamol to formoterol. You switch either with formoterol, salmeterol preparation, not just with SABA preparation, because SABA is not used for long-term control.
So is vaccination recommended in asthmatic patient?
Yes, two most common vaccination, Dr. Nazia, pneumococcal and influenza. Influenza vaccine given every yearly, pneumococcal every 5 yearly. Influenza, very common by the name of Influvac, which is there in the market. Pneumococcal vaccination, again, PCV 13 and PPSP 23. To all those participants, who have elderly parents or parents who are immunocompromised, I tell all my patients to get a vaccination. These two vaccinations mandatory. One is the influenza, one is the pneumococcal. So get an influenza shot every yearly, get a pneumococcal vaccine, and you will get a immunity for at least 5 years. And both can be given on the same day but at different sites. So you give intramuscularly, one can be given at this deltoid region, one can be given at the gluteal region, but it can be given on the same day.
Dr. Zia is asking, injection mucinex nebulization have any role in asthma attack?
First and foremost, there is no injection mucinex. There is either a oral tablet which is mucinex available, and there is nebulization preparation of mucinex which is there. So basically, the role of mucinex, it is a mucolytic, or it acts as an antioxidant. If you see that. So it will help if there is secondary infection, if there is more mucus production, if there is more sputum which is not coming out. So it will help that to mucus plug to dilate, or to that thickening. That will cause that thinning of that mucus plug also. So in attack, you have to suspect whether that attack is due to secondary infection, whether that attack is causing that sputum production or no. If there is no much sputum production, there is no role of mucinex until and unless you suspect a secondary infection or an infection or asthma with sputum production.
Dr. Rahul is asking, post-TB patient present with sob-but ratio is in normal limits. What should be done, sir?
Pardon? Can I have the question again, or let me see the chat? Where exactly is the question?
Dr. Rahul is asking, post-TB patient present with sob-but ratio.
Okay, post-TB patient, shortness of breath, but ratio is within normal limits. What has to be done? So a post-TB patient, as I already told, a post-TB patient can have sequelae. The sequelae follows the disease. So what are the post-TB patients which can the patient be present with? It can either present with post-TB fibrosis, it can present with bronchiectasis, it can present with fibrobronchiectasis. So it can have maybe FE1 by FVC normal limits, but if the spirometry is normal, you can wait and watch. But if the patient is symptomatic and the spirometry is normal, you have to treat that patient. It is very clear. And if the patient doesn't have symptoms, but if the spirometry is not normal, again you have to treat. I hope you are clear. Spirometry abnormal, treat. Symptoms there, treat. Symptoms not spirometry normal, do not treat. So it has to be very clear how exactly the patient present. Symptom treatment has to be there. Spirometry normal, spirometry abnormal, no symptom, you have to treat. Why? Because that worsening of spirometry, FE1 by FVC ratio, further it will cause that symptom. So symptom kara ke hi rahega. Once that obstruction has set in, it will not get better without the medications.
So Dr. Bilal is asking status asthmatics treatment in detail.
I have already told in the slides, Dr. Bilal, status asthmaticus. So basically it is, the exacerbation of asthma. You have to treat it with controller. You have to give short-acting bronchodilators. You have to give inhalational corticosteroids. Along with that, you have to give injection of corticosteroids also. Along with that, if not controlled, you can again give magnesium sulfate. If you suspect a there is a lot of bronchoconstriction, not patient relieved with all that MgSO4 preparation, you put this aminophylline infusion. But again, if you want a detailed or so, I may share it to the team, a detailed how exactly in what dose you have to give as the patient present with that symptoms. Because this will take maybe another 15-20 minutes to explain in detail that acute exacerbation, how that exactly this it has to be given.
So Dr. Raji is asking, till how long can an inhaler be used in an occasional inhaler user?
Inhalers, the patient, it can be given lifelong. It has to be very clear. It doesn't cause harm. It causes more benefits than doing harm. It can be given, yes. So what exactly was the question? For how long? In a SOS basis.
Yes.
So for SOS basis, you have to keep monitoring the patient either with spirometry or with PEFR. You have to check that obstruction, whether that obstruction is getting worse, whether that obstruction is getting either worse or is at the same stage. If that obstruction is getting worse, you have to continue the inhalers. Because if the patient is not having symptoms, but there is obstruction on spirometry, and you do a spirometry, so maybe if the patient is a diagnosed case of asthma, yearly spirometry is definitely advised if the patient is stable. But if the patient is having worsening signs and symptoms, every 6 months. If a patient has more signs and symptoms, every 3 months is also advised. So you have to monitor that patients with spirometry. If not possible, monitor with PEFR level. So how PEFR you will monitor? So greater than 400 to 500 value is a normal. Anything less than 400 to 500 for males is the obstruction, and for 300 to 400 levels, less than that in the PEFR levels is abnormal for females.
So Dr. Turkish is asking, can we use Duolin and Budecort inhalation in mixed solution for nebulization?
Yes, you can use, definitely. You can use a SABA and a inhalational corticosteroids, but better don't combine it. You don't combine it because I think that is I think what's your question कि हम एक साथ ही दोनों को डाल दें, Duolin B or Budecort B. That's what we do. So better do not combine it, because that solubility and that proportionate, that bioavailability of the drug is hampered. So the time you put everything in that, better either you give it mixed with 3% NS or an NS preparation. Do not mix that Duolin Budecort. It is a very common habit. And you see that, you advise in your OPD or maybe in IPD, you tell your nurse or staff to nebulize the patient. And that staff, if the patient is admitted, you come and you ask the patient, how many times nebulization have you been given? So that patient will tell you, sir, I have been given nebulization 2 times only. So you even if the patient is given a nebulization BD, that has to be given 4 times. Means first you give a either you give a LABA, then you give a ICS, or you give a SABA, and then you give a ICS, but that has to be not be combined. So staff, to avoid his workload, that put the SABA, that put the Duolin, that put the Budecort, everything mix up और वो लगा देता है. Put that nebulizer on, that fumes come, and everyone feels कि हाँ, that fume is coming, and oh, you are getting that very good drug. And you tell the patient to open mouth and inhale and exhale. So that you won't get that bioavailability of drug getting deposited and showing the effect at that level. So it should be given differently.
So Dr. Grigari is asking, please explain the use of MgSO4 in severe asthma.
So basically MgSO4 role is again a controversial role, but it is given to precipitate, to terminate the role of, attack of asthma. And especially some role of bronchodilation has been seen of magnesium sulfate. But again, if you see the standard guidelines of asthma, which has been come up in the recent times, they don't basically allow, the use of MgSO4. So earlier and some clinicians also, you see there is a lot of controversy of using MgSO4, but the guidelines say that some role of airway muscles relaxation is there, some role of bronchodilation is there in a patient of acute exacerbation of asthma, which is not getting relieved with bronchodilators, inhalational corticosteroids, or injectable steroids. So a bit of airway muscles that which has been become constricted, magnesium sulfate has shown to be role, but again this use has been controversial. With every guidelines, with every year the guidelines get revised. So basically the role is mostly bronchodilation only and reducing some part of airway inflammation.
Dr. Bilal is asking in which condition adrenaline nebulizer is given.
Basically for asthma conditions, we don't give adrenaline nebulizer basically, but again, adrenaline is a potent, you say a potent vasoconstrictor. So you won't generally give a adrenaline inhalational therapy, but especially if you see, if you do a procedure known as bronchoscopy, if I think if any one of you, if doing this procedure, bronchoscopy or so, and if the patient is having hemoptysis, if the patient is having bleeding in the lower airway tract, you give either adrenaline, you put a vial of adrenaline in the lower respiratory tract. What it does cause, it causes a potent vasoconstrictor. So inhalational adrenaline use should not be there for treating asthma. But again, just to cause vasoconstriction, to prevent hemoptysis and all that role, especially in, these all things should be the role of, these are the role of adrenaline, not as the treatment of asthma.
Dr. Reena is asking, can a preterm child suffer with respiratory problems in later life, having given magnesium sulfate at preterm?
No. See, if you're asking the side, because of the magnesium sulfate side effect it will have, no, not necessarily. But a preterm child having a genetic history of his or her parents having asthma or allergic rhinitis can definitely have respiratory problems, because a preterm child may have some respiratory complications which can further lead to asthma development because of that respiratory problems, because of that preterm condition or a genetic condition of his parents or forefathers or grandparents, but not due to the magnesium sulfate role. It will not cause, the magnesium sulfate as per se will not cause bronchial asthma.
So Dr. Nazni is asking, can cyclosporine be given to asthma patient?
Yes, it can be given, but again, it is basically an immunosuppressant. So for why you want to give, not for the treatment of cyclosporin, but it should be given for a different purpose. Why a immunosuppressant? But the nowhere in the guidelines suggests that cyclosporin is used for the treatment of asthma. But if you're suspecting a different disease in which cyclosporin is indicated, yes, then it can be there. Then it can be given.
So Dr. Saikat is asking, sir, if a person is using inhaler only in SOS basis, with due time, due to remodeling, will asthma become irreversible?
And that is the question someone asked about the asthma COPD overlap. So you see there are three basically entities, asthma, COPD, and somewhere between some features of asthma, some features of COPD. And that's why the name given as asthma, COPD, they overlap. Some symptoms you will have of asthma, some symptoms you will have of COPD. So what happens, a patient of asthma, if put on SOS basis preparation, what happens to that airway? That will remodel. And because of that remodeling, that constriction will set in over the time, going slowly. Because of that constriction, once it has set in, do you think the patient will have reversibility condition on spirometry? Do you exactly think जब वो permanent constriction बैठ ही गया, that has set in, how much inhaler therapy you will give, how much nebulizer therapy you will give, that will not get reversed. So what will that happen? A asthma condition having a irreversible FE1 by FVC ratio on spirometry will be landing up into the COPD condition. So asthma COPD overlap, because of that not controlled thing, will land up into that COPD. And you'll see that most of the patients, if given a SOS therapy during their early life, maybe या तो early life में set in हो जाएगा because of that airway remodeling, because there is no time before for airway remodeling. Airway remodeling begins straight away once you are diagnosed. So it happens. So to prevent that airway remodeling, we give this therapy. So it goes on, it goes on. So it can happen within 5 years, it can happen within 10 years, and it can happen 15 years. So to prevent that asthma landing up into a COPD condition or a asthma COPD overlap, because asthma COPD overlap and then COPD. So ultimately you are pushing the patient of asthma to have COPD. As clear as that.
Dr. Parmanand is asking doses of magnesium.
It again differs. It again differs, and this is again a controversial, as I already told, doses of magnesium. And this I have already discussed in the slide that how much dose of magnesium should be given. So magnesium sulfate should not be used as the first line of therapy for treating of bronchial asthma.
So some doctor is asking, any research going to cure the asthma, like that some research shows diabetes may be cured in other countries?
Permanent asthma cannot be cured. Any doctor who is treating you as a that मैं जड़ से खत्म कर दूंगा मैं that check that degree of the doctor straight away. Asthma can never be cured. That has to be very much clear, kept in mind, because it is mostly an allergic condition. So allergy is basically, a chronic condition. It happens the time you are being born, and it goes with the time you goes from this life. It is very clear, but it is preventable. And preventable to what extent? Preventable to that extent in which you may not need any medication for asthma, maybe lifelong. If you avoid all the allergen triggers, if you are very keen, you are very attentive, you maintain a basic hygiene, maintain a good diet, avoid all kind of triggering factors, drinking cold drinks and everything which trigger asthma, maybe maybe you will not be needing any asthma medications for even lifelong. So any researches are definitely going on, and that's why the biological role has come into play. Anti-IgE, anti-IL therapy, what exactly are they targeting? They are targeting that cells which are being sensitized. What happens when an allergen comes? It causes the mast cells in your body to release that histamine. And because of that histamine, you have that sneezing, nasal congestion, all that skin itching, dribbling from the eyes and everything. All that symptoms come because of that histamine. So these biologicals are targeting that eosinophils so that they do not trigger that cells to release that histamine preparation to cause that symptoms. So they are targeting, and the research is completely going on, and it is there in the market. The biological treatment, which we also do, biologicals, anti-Ig therapy, immunotherapy, you have sublingual immunotherapy, you have subcutaneous immunotherapy, you have either you give a oral drop preparation, either you give a subcutaneous preparation. So these are the therapies which are there in the market.
So Dr. Asha is asking, if patient is on biological therapy, can we stop inhalers?
Basically, if the patient is on biologicals, you don't have to stop inhaler because biologicals take time to show their effect. So if you stop the inhaler and you don't expect a miracle by giving a 20-25,000 omalizumab or mepolizumab shot, it will take time. And you have to tell the patient from the dose of day one ki bhai, injection mein laga raha hu, it will maybe show effect in 6 months, it will show effect in 1 year, and maybe it may not show also in some patients, but it will show. It will take time. So in that time period, the patient can have that worsening of symptom, shortness of breath, and the patient will come to you, doctor, I have given 25,000 rupees to you. And you have stopped my inhaler also, saying that this is the magical injection which I am giving, but my symptoms are the same to same. So you don't have to stop that any medication for asthma. Continue that. And again, till the time the patient's symptoms become improved over a period of time. And you will see that improvement in symptoms once the use of biologicals.
So Dr. Raji is asking, patient gets moderate wheezing if exposed to dust and gets better within hours without any inhalers. Will this patient need to take any treatment or any tests to be done?
You test everything as per se of asthma. You clinically evaluate the patient, you get a chest x-ray done, you get a spirometry done. And again, if you want some blood investigations, again, serum Ig, absolute eosinophil count, and you check the pulse oximeter, you monitor the vitals. This is again a typical symptoms of asthma. and the patient is getting mild, maybe due to a, falling into the step one of an intermittent phase, which may get worse if not dealt on time.
Which beta blocker should we use if required?
See, beta blockers are definitely contraindicated because they can cause bronchoconstriction, specifically if you want to use beta blockers. But again, cardio safe beta blockers, not the beta blockers. If you say carvedilol, metoprolol, this can be given, not the beta 2 receptor this beta 2 blockers. The beta blockers which are acting on maybe non-specific beta blockers can be given, not the beta 2 specific beta blockers acting on the beta 2 receptors.
So can the patient require cardiorespiratory rehabilitation with physiotherapist?
Yes, cardiorespiratory rehabilitation is indicated and mandatory for a patient of asthma, because if asthma is not controlled, his cardiac, his lung function will get compromised, and you see that lung and heart operate on a parallel basis. If there is a load on lung, ultimately your heart will also have a loading kind of phenomena. So that cardiopulmonary rehabilitation has to be started from the time the patient is diagnosed and he is clinically stable. Exacerbation mein you don't do a rehabilitation. You don't do a spirometry. The patient is gasping and you are telling the patient to do yoga, to do that spirometry, to do spirometry or to do an incentive spirometer. He will crash, he will collapse. That symptoms has to be settled. The patient should have no symptoms. Then you do a rehabilitation. You tell the patient to do a spirometry. You tell to patient to do chest exercises. You tell the patient to do coughing, huffing, diaphragmatic exercises, all kind of rehabilitative phenomena.
So one doctor is asking, can we give tab MBBS AB in bronchial asthma, dose and duration?
See, Amicast AB, if you are talking about, it is a combination of N-acetylcysteine and this Mucinex. N-acetylcysteine and acebrophylline. Acebrophylline, yes, acebrophylline. And so basically by the name of Mucinex AB, Agmi-Mask AB, which is there in the there. No specific role in asthma if the patient has no sputum production, no secondary infection or so, because the whole and soul of this dual combo is mucolytic and antioxidant. So if there is no mucus production for which you are giving, why you are giving? Just to give a bullet therapy just for that placebo effect, there is no role. The patient will get settled with inhaled corticosteroids, bronchodilator preparations as so.
So one doctor is asking what drug to advise in patients of rhinosinusitis, not reliever by levocitrazine, Monty.
Intranasal steroids. Plain, either international steroids or plain, either you can give a fluticasone preparation, or it can be sometimes combined with azilastine, but again, not on a long-term basis. Intranasal steroids can be maximum given up to 4 to 6 months. Maximum it can be given if the patient is diagnosed the condition of allergic rhinosinusitis. Just to put the patient on plain fluticasone preparation.
Asthmatic patient in HTN in give amlovas 5.
Yes, you can definitely give it. Is safe. Yes.
I guess we are done with the questions. So thank you so much, Dr. Ayush, for this informative session. On the behalf of everyone, I extend our sincere gratitude to you, Dr. Ayush. Actually, it is this kind of engagement and the participation that motivates us to organize more such webinars in the future. Thank you so much, Dr. Ayush.
Just one question I would like to take, Shaban. Shaban was asking about magnesium sulfate. So as it is not the gold standard for treatment of asthma, and the role and the dose of magnesium sulfate has been always controversial. You can always give maybe 1 to 2 grams IV, and again, it has to be given either in a dextrose or a normal saline preparation. Maybe you can give around 50 to 100 ml in 5% dextrose or normal saline, but do not give 1 to 2 grams more than that. But again, use only for exacerbative phase. But again, if not controlled with all inhalational corticosteroids, not controlled with injectable steroids, not controlled with bronchodilators, short-acting, long-acting, then think of magnesium sulfate. Better go for aminophylline preparation. You can give an infusion of it.
Surely. Thank you so much, Dr. Ayush, for the one. everyone, please do fill. Will
So
be
someone
pasting.
was asking just, I think, is there a role of FeNO? There is a role of, see, FeNO is fractional exhaled nitric oxide, and I already told the levels of it. Less than 25 is almost normal, 25 to 50 is intermediate, and greater than 50 is again indicative of asthma. But to sure diagnose, go for spirometry along with FeNO. So FeNO is some kind of a, just to, because of that, the inflammation which is going on in your airways, that inflammatory cells release that exhaled nitric oxide which you blow in that FeNO machine. So that levels is being measured of exhaled nitric oxide. That's why the name given fractional exhaled nitric oxide, not the inhaled.
Do we have any more questions, Dr. Ayush?
I don't think, because I was scrolling through the chat, so I think we have covered every question.
I guess yes, we are done with the questions now. If there are any further questions, you can ask, or else we have completed the session. Thank you all for joining us today for this wonderful webinar from Dr. Ayush. So if you have any further questions or would like more information, please feel free to reach out to us. And don't forget to follow us on social media and WhatsApp channel for future updates. Again, I'll be sharing the certificate registration form in the chat box. Please do fill the form and you will be receiving your certificates on your mail ID. Please do fill the form. Thank you, Dr. Ayush, once again.
Thank you so much, Shabnam. So thank you all, and I hope that it was an informative session. Just to wrap up this session, key takeaway points. The gold standard for diagnosis of asthma is definitely clinical. You go for spirometry, you check for reversibility, and then inhalational corticosteroids with bronchodilator preparations on a long-term basis for a stable patient, and treat exacerbation or worsening of the signs and symptoms accordingly. This has to be very kept clear in mind. Do not treat asthma as the patient of, just like you treat a patient of COPD. These both are completely different diseases. The mode and approach for these two diseases are completely different. Do not follow the same monotonous routine which is being followed. Thank you.
Thank you, doctor. Thank you, everyone. Have a good day. Bye-bye.